This training presentation introduces a care pathway for urinary tract infections, or UTIs, to dip or not to dip. The aim of this pathway is to improve the quality of care for older people living in care homes with suspected UTI. It focuses on how you, as care home professionals, can improve the diagnosis and the management of suspected UTIs, and can also help to prevent UTIs in your residence. Let's start with a quick quiz to get you thinking about UTIs. How much urine should the average adult produce in 24 hours? The answer is 1.5 litres. Who is at greatest risk of a UTI? The answer is women. The answer to this is that women have a shorter urethra than men. The urethra is the tube that connects the bladder to the outside. This makes it easier for bacteria that live inside the bowel to get into the bladder. What time of year are UTIs more common? The answer is summer, and every year there is a summer peak of hospital admissions for the most severe type of UTI, bloodstream infections. What percentage of care home residents are prescribed an antibiotic for UTI in a 6-month period? The answer depends on the type of care home. There is wide variation in practice. The original To Dip or Not to Dip project team collected baseline data from 23 nursing homes in the southwest of England, and they found that up to 43% of residents there received an antibiotic for UTI. However, after introducing the To Dip or Not to Dip pathway, this was reduced to just 19%. This suggests there may be scope for reducing the amount of antibiotics prescribed to older people, and we will discuss why this might be beneficial. You may have guessed from the name that the To Dip or Not to Dip pathway relates to urine dipsticks, but first, let's recap what a UTI is. The urinary tract consists of the kidneys, which filter the blood and produce urine, the ureters, which are the tubes connecting the kidneys to the bladder where the urine is stored, and the urethra, which is the tube through which urine leaves the body. Bacteria normally live in the bowel and on the skin, but can enter the bladder by travelling up the urethra. In the bladder, they can grow and multiply and may cause symptoms of an infection, which are pain on passing urine, needing to pass urine more frequently or more urgently than usual, new incontinence or worse incontinence than normal, pain in the lower abdomen where the bladder is, or in the flanks where the kidneys are, shivering or chills, or a high or low temperature, and in older people they may become more confused or agitated than normal. Smelly or dark urine alone are not signs of a UTI, but may be signs of dehydration. Bacteria in the urine does not always mean an infection is present. In older people, bacteria can live harmlessly in the bladder without causing any problems. This is not an infection, as the bacteria are not causing harm to the person, and treating with antibiotics does not reduce future infections. In fact, antibiotics can be harmful and may lead to more infections in the future by disrupting the balance of the body's bacteria. So what proportion of older people living in care homes does this affect? Well, studies have shown approximately 40% of men, 50% of women, and 100% of people with indwelling catheters have bacteria in their urine without an infection being present. The urine dipstick will most likely be positive for nitrites, a chemical most bacteria make in the urine, and leukocyte esterase, which shows the presence of white blood cells. There may also be other markers, such as protein and glucose, which are unrelated to infection, but often present in older people. But none of these tell us whether or not there is actually a urinary tract infection. For this, a clinical assessment of signs and symptoms is needed, and the national best practice guidelines support this approach. But what's the harm in dipsticking? It is very difficult to ignore a positive result, even if it doesn't mean very much at all. It can be difficult to assess older people, for example if they are confused, and relying on the urine dipstick result in this setting may result in another diagnosis altogether being missed. It can also trigger antibiotics being prescribed. Antibiotics are powerful and precious drugs. Giving an older person antibiotics when they don't really need them can lead to side effects such as rashes, stomach upsets, or drug interactions. Clostridium difficile diarrhea, or C. diff, is a life-threatening infection of the bowel, and it is caused by antibiotics. You may have heard of antibiotic resistance. This happens when bacteria are exposed to antibiotics and then adapt so that they are no longer killed by the antibiotic. This means antibiotics won't work when the person really does need them. In fact, 1 in 3 older people will suffer side effects from antibiotics if given them inappropriately. So it is important to only use them when there is strong evidence of an infection. The to dip or not to dip pathway supports you as care home professionals to recognise and record the signs and symptoms of a UTI and communicate these clearly with the GP or other clinician. An assessment tool based on the Scottish National Guidelines has been developed with specialists in the care of older people. Crucially, urine dipsticks are not used when a UTI is suspected. Instead, use the assessment tool. If a UTI is likely, the tool guides you on the next steps you should take. Contacting the GP or relevant health professional during normal working hours and obtaining a urine sample for culture. Outside of normal working hours, you can still use the assessment tool to help you assess your residents and communicate with care providers, but follow the usual out-of-hours care pathway. For example, NHS 111. If the resident is very unwell and you would usually get urgent help, then do this as you normally would. Urine samples are very important to obtain wherever possible, as they are used to grow the bacteria in the laboratory and test it against a number of antibiotics. The result of this can help the clinician to choose the best and safest antibiotic to treat the resident. Boric acid or red top specimen containers are preferable when sending urine samples, as they contain a powder that is a preservative. This means that the urine sample can be processed by the laboratory a number of days after it has been obtained, whereas urine in a universal or white top container goes stale within hours. Fill the red top container up to the line to ensure the right ratio of powder to urine. If there is only a very small volume of urine, less than 10 millilitres, it is better to send it in a universal container to avoid the sample being rejected by the laboratory. Ensure the sample is carefully labelled with the resident's details and that the GP has the details from the assessment tool to write on the request card. Using a urine collection system, such as a Newcastle pad, may be useful in residents with urinary incontinence. In residents with indwelling urinary catheters, a sample must be taken in a special way by a registered nurse. The catheter should be changed as soon as possible if the resident is started on antibiotics for possible UTI to prevent the infection from relapsing. There is now the opportunity to practice filling in the assessment tool using these case details. What boxes would you tick? What actions would you need to take? Pause the video here for a moment whilst you fill in the form. Let's check how you did. Firstly, no dipstick. Are the resident's details filled in? none of the first box should be ticked. She's not catheterised, so use this box. You should have ticks for new or worsening incontinence, need to pass urine more urgently than usual, new or worsening confusion, and a temperature with 38 degrees written in. There are 2 or more ticks, so a UTI is likely. And so action should be taken to contact the clinician and obtain a urine sample. The form should be filed in the resident's notes as a permanent record. We've all heard the saying, prevention is better than cure, and this is very true when it comes to UTIs. So how can you prevent UTIs in your care home residence? Preventing dehydration is a key intervention. Why do older people become dehydrated? Memory impairment means that they may forget to drink. They may not be able to communicate their needs clearly. The sense of thirst becomes blunted with age. Certain medications may contribute to fluid loss. Living in a warm environment means they lose more water. All of these put a strain on the kidneys, meaning less urine is produced. Older people tend to spend longer periods sitting or lying down, so urine stays in the bladder for longer. Dehydration also causes constipation, which can compress the urethra and lead to incomplete bladder emptying. If harmful bacteria enter the bladder and are not flushed out promptly, they may multiply to cause an infection. How to recognise the signs of dehydration in your residence by taking a top-to-toe approach. Headache, tiredness, a dry mouth or tongue, cool hands or feet, urinating less than 4 times a day, smelly or dark urine. The urine colour chart can help with this. So looking in a resident's mouth and looking at the colour of their urine is a quick and simple way of identifying residents who are dehydrated. What can you do to prevent dehydration? Residents should drink between 1.5 and 2 litres of fluids per day. This equates to around 8 glasses or cups. If a resident is on a fluid restriction, then follow the advice of the GP on the volume of fluid they should have. Take a moment to think about how much your residents have to drink in a day. Not just how many drinks are offered, but how you might know what is actually being consumed. It is easy to see how unfinished drinks may be cleared away if a resident walks away or falls asleep in the chair, or if the cup of tea goes cold. Regular bladder emptying is key to preventing UTIs. So helping residents to the toilet at regular intervals throughout the day, especially after a long period of sitting or lying down. Seek advice quickly if a resident becomes constipated, and if there are particular continence issues, contact a continence specialist for advice. The original To Dip or Not To Dip project not only reduced antibiotic prescriptions, it also reduced emergency hospital admissions for UTIs and for dehydration. To Dip or Not To Dip is now taking off across the country, with many areas now taking this approach. Information about antibiotic prescriptions and hospital admissions is collected to demonstrate the improvements made and to continue to identify new ways to improve care. By using the approaches discussed in this video, you can make a real difference to your residents by preventing dehydration and UTIs, avoiding the risks of unnecessary antibiotics, and improving the quality of care they receive.